Good evening, and thank you for joining me for this talk. My name is William Trask, and I'm one of the second-year residents at the University of Calgary. We'll be focusing on a project I've had underway with Dr. Jamie Bamra, which focuses on cytomegalovirus-associated endotheliitis here in the Canadian population. Here are the objectives of this talk. Firstly, we will review cytomegalovirus as a cause of ocular infection. Then we will provide an overview of the existing research surrounding this entity. Third, we will provide an overview of our novel research concerning CMV endotheliitis here in a Canadian population. And finally, we will explore a possible treatment strategy that is well tolerated long-term for these patients. So what is cytomegalovirus? Well, it's one of the human beta herpes viruses that is ubiquitous throughout society, with seroprevalence being estimated as high as 90%. It has an initial unspectacular infectious phase, but then remains latent in the bone marrow and can be reactivated by immunosuppression. In the ocular sense, it is perhaps most renowned for its devastating retinitis that is associated with profoundly immunosuppressed states, such as HIV. However, in the last 15 years, it has become increasingly recognized that the so-called latent stage of CMV is not innocuous to the eye, and indeed, it has been associated with recurrent keratouveitis, Posner-Schlossman, and Fuchs. Most specific to this talk is the topic of CMV endotheliitis. This was first reported on by a Southeast Asian group, Kozumi et al., in 2006, where they provided a case report of a single male patient with corneal decompensation that was subsequently found to be associated with a positive CMV anterior paracentesis. Indeed, there's now a bevy of research in the Asian literature that establishes CMV as a cause of recurrent endotheliitis and has defined some of its characteristic features, including the sursnit KP and the linear KP. It is important to note that this disease has a chronic relapsing remitting course, and that the typical mainstay of treatment is either valganciclovir PO or topical ganciclovir, each of which are not particularly well tolerated long-term due to, in the former case, bone marrow suppression, and in the latter case, the risk of corneal toxicity. So this brings us to our chief question, and the question is threefold. So firstly, given that the near entirety of literature comes from Asia, is this entity present in other populations? And if so, why is it unrecognized? Secondly, in those other demographics, does it vary in its presentation or clinical features? And finally, is there a reasonable, long-term, tolerable regimen for treatment and maintenance in order to prevent some of the recurrences? So looking at our methods, we performed a retrospective review of patients over an 8-year period who presented with endotheliitis and or recurrent anterior uveitis, and who were subsequently found to be CMV positive on AC paracentesis, and that test was performed by PCR. All of these patients received the typical treatment of a minimum 12-week course of valganciclovir PO, and subsequently were weaned and tapered at the treating surgeon's discretion. Here are our results. In total, we collected 9 eyes of 7 patients, 4 of whom were female. These were all immunocompetent patients. 2 of these patients were of Caucasian descent, most notably. And I think our mean follow-up was quite impressive at an average of 76 months. The features that we established were consistent with those reported in the literature largely, with epithelial and stromal corneal edema and chorotic precipitates, with the majority being of the sursnit or linear pattern that has been previously reported. 2 of these patients had profound endothelial failure progressing to DSEC. Going through a graphical portrayal of some of our results, you can see that there was a statistically significant reduction in the intraocular pressure of these patients with their valganciclovir treatment. Similarly, initiation of treatment was associated with a reduction in the steroid burden, topical steroid usage that is, and a trend towards a reduction in the number of anti-glaucoma medications required, although this was not found to be statistically significant. Valganciclovir was well tolerated in this series, with no patients requiring discontinuation due to side effects. On average, patients had 2.3 exacerbations, and they were able to be successfully managed long-term at actually a remarkably low dose of valganciclovir, with most patients being controlled with fewer than 3 doses per week. That is less than every other day. So moving to the discussion, our series provides the first report of CMV endotheliitis in a North American population, although, as you can see, the majority of our eyes are still of Asian descent. Now, I think that there's still an open question as to exactly why there's an increased incidence of CMV endotheliitis in Asian populations. And there's a possibility that this is due to varying levels of seroprevalence, differing strains of the virus in different environments, or the genetic differences between demographics. Overall, we have a similar pattern of clinical features in our Canadian population as compared to the existing Asian literature. But it's interesting that neither of the Caucasian patients had the so-called pathognomonic succinic KP, and overall we had a lower incidence of that finding. And finally, our findings support the possibility of very low dose and perhaps an unprecedentedly low dose valganciclovir maintenance therapy for the long-term management of CMV endotheliitis. So in conclusion, CMV endotheliitis is present in Canada and I believe is clinically important given that it has a tendency to progress to decompensation that requires surgical management if untreated. Finally, our series suggests that eyes can be successfully maintained quiet long-term on low-dose valganciclovir and minimal topical steroid, successfully avoiding the known side effects of each. Thank you very much for your attention, and I will now welcome any questions.